about establishing of this nice organization, MENA-SINO, and arranging of this webinar. Now I'd like to start about my presentation is about stroke in Iran. It takes about 20 minutes. After that, Dr. Merpur, president of Iranian Stroke Association, present some cases about intracranial stenosis, some difficult cases. And after that, if we have time, Dr. Sharifipur join and present some cases, other cases. About my presentation, you see here, I don't have any disclosure. About content of my presentation, you see here some introduction. After that, epidemiology of stroke in Iran. I will present some slides. After that, about our stroke program in our country, and in the end, about SITS, our country in SITS. As introduction, as you see here, Iran located in the southwest of Asia with area of about 1,648,000 kilometers square. About size of our country, it ranks 16th. About climate, our country, it ranges from subtropical to subpolar. Our country have about 30 provinces. The most population of city, you see here, the Tehran is more populated, about 6 million. After that, Mashhad, Isfahan, Tabriz, and Shiraz, they are the five big cities of our country. About population, our country have about 83 million population, more than 12 million living in the capital city of Tehran. We have many different ethnic groups, including Persian, Azeri, Gilaki, Mazandarani, Kurd, Arab. We have many culture in our country. About urban population, we have about near 70% of our country living in urban area. About age distribution, as you see here, the most of population is in the range age group of 15 to 44 years. It is important because it means that after about 20 years, most of our population in our country will be aged and of stroke in near future. It is important health issue in our country. Based on WHO report, life expectancy for male is about 69 years, and for female is 73 years. And based on a report of Ministry of Health, now stroke is detected as the second cause of death in our country after myocardial infarction. About our neurologists, we have about 1,000 neurologists in our country, about 150 of them living in Tehran, and we have about 30 stroke neurologists in our country, and about 20 neurointerventionists are in our country. What about epidemiology of stroke? We have two types of publication about epidemiology. Some hospital-based studies, the most of publication based on hospital-based, and other type of epidemiology study is population-based. Usually these studies have a high CAS difficulty in undertaking, usually have a strict method, but in the end, finally, we have a good and real result based on population-based study. About hospital-based study, we have many publications about that. In 2010, Akram Hosseini and colleagues have a meta-analysis about that. Based on analysis and other studies after that. You see here many studies in this table. Male and female ratio is near 50%, near together. The mean age of our cases based on these studies about, you see here, 63 to 67, and young adult cases range from near 5% to 40%, and middle adult cases near about 30 to 39%, and old cases, you see here, they range from 46 to 64% of our cases. About this factor, based on the hospital-based studies, you see here the hypertension is most common risk factor in our cases, range from 50 to near 70%. After that, diabetes mellitus range from 30 to 36%. Smoking range from 12 to 20%. After that, hyperlipidemia about 8 to 32%. Valvular heart disease in this study only about 70%. AF range from 4 to 14%. And mortality of our cases in 1 to 3 months range from 7 to 31%. What about population-based studies? We have 3 published population-based studies. The large one is MENA-SINO stroke incidence study with abbreviation of MENA-SINO, the large one. Other is Southern province stroke study is only about ischemic stroke cases, and other one Tabriz stroke study. This study is a cluster based in about 1,000 family. I know because of limitation of time, I am only explain the large one, the MENA-SINO study, and studied in Mashhad. This is study a large study in 2006-2007 in a population of about 500,000 population. In these cases, and in this year, we have about 624 first ever stroke cases. Current rate of first ever stroke based on this study was 139, in the range of 128 to 149 per 100,000 population. When this number adjusted to European population age, this became more higher. For ischemic stroke, incidence increases to 616 cases per 100,000 cases. About ICH, it increased to 94, and for SAH, it increased to 12. This study showed that we have excessive incidence of a stroke in Mashhad as a large sample of our country. And the other result of this study was that age-specific incidence of stroke in our country is 1 decade earlier than European countries. In this slide, you see Mashhad study comparison with other population-based study. Mashhad is here the black bar. You see here in each age group, and incidence of stroke in Mashhad is more higher. This is slide only about ischemic study, but in this slide you see here all stroke cases. If we consider all stroke cases, incidence of stroke in our country based on this study is second one after Ukraine. You see here stroke subtypes. In Mashhad study, more of cases near about 70 ischemic stroke, after that ICH, after that subarachnoid hemorrhage. Based on WHO reports, here. Iran included in high quartile of stroke incidence. You see here quartile 4. Our country included here, such as Russia and Tanzania. Based on, again, WHO report about mortality, our country included in second quartile with mortality of about this group 30 to 40 per 100,000 cases. It means that our mortality, annual mortality, is about 721. About stroke risk factor, based on Iran STEP survey, you see here hypertension is the most common risk factor in our cases. After that, diabetes mellitus, smoking, hyperlipidemia, and after that, AF. What about thrombolytic therapy in our country about stroke? Thrombolytic therapy in our country started since 2008 as a discreetly in some university and some private hospitals. About 2030, we have the one system thrombolyte in one university in our city. And 2 years later, we have a national stroke movement since 2015 by collaboration of Ministry of Health and Iranian Stroke Organization. Based on this national stroke movement, in our country, stroke units defined based on primary and comprehensive stroke centers defined in our country. A stroke code defined, a stroke hospital defined, again, bit code of 724 hospitals. It means that hospitals are ready in 7 days and 24 hours. Based on this national stroke movement, RTPA was covered by health insurance. EMS activated about stroke detection systematically, and related courses were held for EMS, nursing, resident, other colleagues. Air transfer in some cases defined. National stroke guideline and document published by Ministry of Health. And after that, we have routinely every year World Stroke Day program in whole cities of our country. This is the first air transfer of stroke cases in 2014. And about Iran activity in SIDS registry, as you know, SIDS registry is the worldwide and the biggest, largest stroke registry in the world. Our country registered in SIDS since 2013, and we have now about 15 centers registered in SIDS, as you see here. Right now, as I checked yesterday, we have about 8,500 stroke patient data entered in this registry. Based on last year report in Milano, in ESO, Iran included in the top 20 recruiting countries, as you see here. Last year we have about 3,000 cases in SIDS. And again, based on last year report, based on SIDS meeting in Milano, if we consider all protocol of SIDS, Egypt is considered the biggest center. In Egypt, there is about 3,800 cases last year. Good progress in comparison to 2014. After that, Iran have a big progress in comparison to 2014, as you see here. But if we consider about thrombolytic activity, our country have a biggest progress in last report. You see here, we have about 1,300 cases, thrombolytic cases reported in this here. You see here, after that Qatar, but after that Egypt and Europe, Arabic Emirates. And this activity is, I think, based on our national stroke movement. We have this progress, and I believe that if we have a near collaboration, we can increase our power against stroke. Thank you very much.
Thank you, Dr. Mahdi, for your descriptive lectures about the situation of stroke in Iran. I have a question. I think from your slides, you showed that there is a higher number of young age that have they are victims for stroke in comparison to the other part of the world. Do you have any explanation regarding this phenomena in the Iranian population? Is that due to increased risk of cardiac diseases, something like risk factors, special risk factors in young age?
Yes, I think it is same about myocardial infarction. In myocardial infarction, the age decreased 1 decade earlier, such as a stroke in our country, unfortunately. I think it is maybe lifestyle changes and maybe some due to increase of decrease of activity. I think physical activity decrease maybe due to some lifestyle, I think, and maybe some stress. I think maybe important in our country. We have sometimes more stress, maybe psychological stress sometimes in publication.
Special type of diets or something like that. I think your Iranian diet is very sweety, and we tend to have some very delicious sweets from Iranian kitchen.
Thank you. Thank you.
Okay. Anyone have any question regarding first lectures from the audience? I think no. So we can go to the next lecture.
Yes.
Yes, please.
Dr. Mehpur, our president of Stroke Organization. I invite Dr. Mehpur, please.
Yeah.
Hello, and thank you very much to inviting me to this meeting. Actually, Dr. Farhudi, it was about, I think, 1 week. It was about last week that he called me and he said me about this program, and it's my pleasure that now I am here and I can be participate with you, and we can share our experience with each other. As Dr. Farhudi, he said to me that bring some cases or some topics that could be challengeable or disputable. I think in just maybe less than 20 minutes, I try to provide a small lecture about something that's, I think, still it's challenging for us. And if you let me, I will start my lecture.
Please.
Yes, please, kindly.
Actually, my lecture is about intracranial stenosis. I don't know that you have my picture or not, because I have some.
We have your pictures, but we don't have your slides. You can share your slides with the green button from the down.
If you give me time, I will give you yes.
Yes. Yes. It's now on. Your slide is on.
Yeah, just a minute. This is about intracranial stenosis. That's, as you know, the prevalence of the intracranial stenosis, it's somehow different between parts of the world. We have different, I think, numbers of the patients who suffer, and there is different reports from, for example, in the North America, or from the Africa, or from the Eastern of Asia. It's interesting for Iran. I had only found one article that it was about the rate of the intracranial stenosis. It was in Shiraz about 3 years ago. It was done, and they showed that about 25% of stroke patients is due to intracranial stenosis. But they evaluated the patient only by transcranial Doppler, not by, for example, CT angiography. It was not confirmed by other modalities. But we expect this maybe could be near to the other parts of our region. For example, as we know, the most of the intracranial stenosis is, for example, in African American and also Asian, especially Chinese, Japanese, and also India. And we think that as we have experience about the patients in our country, intracranial stenosis is so common. I started just with one case and then continue my topic. We had a few years ago a patient with diabetes and hypertension and heavy smoker. He has 68-year-old and history of stroke, but old stroke, that he could do his work, and there is no problem for him. And only he said that I had some problem in my left side. For example, it was about a long time ago, but now I am okay. But for a few weeks, he found a new problems repeatedly, somehow transient aphasia and right hand paralysis. Evaluation found, and except that apart from the old stroke, we found also that the patient in angiography we saw, that's very interesting. As you see here, he has right in ICA occlusion, complete occlusion, as you see here, and from the left ICA, that when we inject the dye, there is a dye in the ICA that is diseased itself, and atherosclerotic, and it's disease, it goes up, and the flow goes to left side, to the left side MCA, and also to the right side MCA and ACA. That means that the left ICA complete both sides, try to give blood for both sides. And it's interesting that it has also the problem in the M2 branch in left side, severe stenosis at proximal M2 branch here, as you see. And the patient found repeated aphasia, and we thought that this patient is at high risk, and also he was under treatment of the aspirin and, if I'm not mistaken, atorvastatin 40 milligram. We thought that for these patients, maybe it doesn't make any sense. It's somehow on best medical treatment and repeated TIA, so we decided to treat the patient by intervention. And for this patient, because it was not so easy, we put two wire, micro wire, one in the branch that's apparently normal, and the other in the stenosis part, because we wanted to put a stent, and we have concern about that maybe with inflation of the stents, it can cause the sacrificing the other branch. So we put another wire in the normal branch. And fortunately, the branch was okay, and we could open it, and the flow was significantly better, and the patient condition also was good, and the attack, it was not again repeated for these patients. What about the pathophysiology of the intracranial stenosis? As you know, we have some intima and adventitial proliferative fibrosis more common than other parts of the extracranial, and also degree of luminate stenosis, and also much more lipid in the plaque, and also intracranial hemorrhage can indicate that there is much more risk of stroke in these plaque. This is somehow like plaque morphology also in the, for example, carotid. In carotid also we have this neovascularization or plaque hemorrhage. They can also say or alarm us that there is much more risk of the stroke and going up the plaques. And also it's interesting that calcium deposits in the degenerated media are less common in intracranial artery in comparison to coronary artery. And about the risk factors, actually, the most risk factor that we can mention, some of them, as we know, there is not modifiable risk factors like age, like race, like gender and family history, and also one of the most important, radiotherapy and polymorphism and some other genetic factors. But for modifiable, especially in our experience and in our country, we see especially patients with who suffer simultaneously diabetes and also hypertension and smoking. These patients, most of the time, we find that they suffer, unfortunately, from the intracranial stenosis. And also, limiting physical activity also is very important for intracranial atherosclerosis risk factor. Diagnostic procedure that we can expect that it can prove or find this intracranial stenosis, as we know, it could be transcranial Doppler, MRI angiography, or CT angiography. For transcranial Doppler, it's interesting, and also for MRI angiography, negative predictive value for both of these procedures are high, are quite high, and it could be good for screening matter. But unfortunately, the positive predictive value is not is somehow low. It's about 50 to 55%. But on the other hand, CT angio can detect correctly and exactly similar to the somehow similar to the DSA, the stenosis and the rate of the stenosis of intracranial vessels. So CT angiography is the preferable choice for diagnosing of intracranial stenosis. But we have some other advantages for the modalities like TCD. Like microembolism detection, it's interesting that we can detect microembolism, or like hits, as we say, in distal parts of the severe stenosis, and it can show us if we find microembolism within 3 days after a stroke. It can show us, and also it can say to us that the risk of a stroke in the next year, it can be more than 8-fold. So it's very, very important as a prognostic factor. Also for MRI, nowadays MRI, especially 3 Tesla MRI, they can also detect the morphology of the plaque, and as I mentioned before, they can also say that intraplaque hemorrhage and about the lipid core and fibrous cap, and all of that they can detect that this is the high risk of the, for example, intracranial stroke in the future. And we can see in this diagram some advantages and disadvantages or limitation of the different procedure that we can use it. But as I said, CT angiography in these three modality is the most accurate between these three modalities. Actually, it's very important for intervention, as we think that so it could be better that for all of the patients who suffer from severe intracranial stenosis, we do intervention. But unfortunately, during the different reports, and also the most important was samples, it showed us that the best medical treatment is superior to intervention, because the complication of the intervention cause more mortality and hemorrhage than medical treatments. But should we accept and should be convinced with samples and visit trials that they say that endovascular is not suitable even for subgroups, because for subgroups also the risk of endovascular again is high. I think we should think about it. And nowadays also we see some of the new articles that they come out and they say that we can do intervention for some patients, especially for patients with recurrent TIA or stroke, even when we use best medical treatments. After samples, the FDA said for wingspan that was approved by our FDA for intracranial stenosis, it was restricted the use of the wingspan. I think also the usage of wingspan is not so friendly, and maybe because of that, there was some risk of complication. And maybe this is one of the factors for being not unsuccessful result of the intervention. There is also, I think, some new methods that they will come to us, and they may change our mind or strategy for treatment of intracranial stenosis, like FFR. As you know, fractional flow reverse. The cardiologists, they are very familiar with this index, and they can decide for putting a stent or not by determining this FFR. And also we have new technology with time of flight MRA. It also can determine this flow. I think in the near future, maybe it can also be a good strategy for determining which of the treatment is best for patients. Another suggestion that nowadays some interventionists they say about it's about ballooning. They say sometimes ballooning may be better than stenting because it can cause more or less complication, and also about the cheesing effect or glowing of the plaque during intracranial stenosis. But actually, in experience that I see and my colleagues, in ballooning, the stenosis sometimes it will be recur, and it's not so successful as stenting. And what about best medical treatment? Still, I think there is also some improvement. For example, nowadays they said that maybe using NOAC could also be effective for treatment as a best medical treatment for patients with intracranial stenosis, but it could be tried, I think. I have some other cases here that I want to show you. This patient, like, for example, had a right hemiparalysis that was repeatedly after best medical treatment. So it's in the last part of the left MCA, as you see. and we put a stent. Actually, the stent that we use it here, we use the coronary stents, the subtype of the coronary stents that they can navigate the actually the hard way or road of here. And fortunately, we could put it here, the stent for opening the vessel. And this is another patient from proximal part of the MCA. As you see, he has repeated stroke, and so we put stents, and fortunately we could open it successfully. And at the end, I just wanted to show the miracle of the maybe stroke nowadays, and that's intervention in stroke treatment for if the patient comes at the correct time and at the right place and right person, the patient really can be saved. And it's really, I think nowadays it could be a miracle of the medicine. Thank you very much. And
thank you, Dr. Masoud, for your interesting presentation. I think it's a more innovative, it's more descriptive for the situation of the intervention in the of the intracranial atherosclerosis in Iran. I think we sharing similar numbers regarding the incidence and the prevalence of the intracranial atherosclerosis. As I see in your lecture, there is a high incidence of intracranial atherosclerosis in Iran, and also from our some published studies in Egypt, there is also prevalence of about 35 to 50% of stroke is due to intracranial atherosclerosis in Egypt. And I think we should have something that something like trials that is based for our region to examine the efficacy and the safety of the interventional treatment for such a treatment, because you know that the SAMPRAS is designed in centers of with low flow for intracranial atherosclerosis, because you know that intracranial atherosclerosis in USA is as small when compared to the Far East and our region. So I think yes, I agree with you that the message that coming from the SAMPRAS and the visit should be taken in a cautious way, and we should caliber and size our randomized control trial to find our own result for our own patient. And if you are interested, we can design something like that. It's I think also the situation in Pakistan is similar to Egypt and Iran. The incidence of intracranial atherosclerosis is high, and I think if we decided to run something like that, it will be very interesting. And I have a question regarding the your technique in making angioplasty. You passed the two wires, one for the superior trunk of the middle cerebral artery in the first case, and the other one in the inferior trunk of the middle cerebral artery. I couldn't catch the rationale behind this one. You putting the wire inside the non-diseased artery because of the fear of if you do angioplasty or stenting, it could be occluded or something like that?
Yeah, exactly. Because, you know, as you see here, it was really near to occlusion. It was about maybe less than 5% here, as you see, the stenosis here. And if I wanted to put a stent from here to here, so with expanding the stent, I have concern about that maybe it can compress this vessel, and it can maybe sacrifice this flow also. And I put my second wire here, that if I found a problem like that here, I will put another stent here, and it could be like a missing stent.
Oh, yeah. So this is gets me to the other questions. Which type of stent you frequently use? It is a coronary type, balloon-mounted stent, or self-expandable stent?
Actually, we don't have nowadays. We don't have wingspan, and so this is I obliged to use coronary stents, and most of the coronary stents, as you know, they are really hard for the intracranial vessels. The most suitable for me is the stent Promus, and also sometimes the Omega stents. They can really good. They are good flexible in these parts, but unfortunately we didn't have. As I said, nowadays we don't have wingspan. I use balloon mounted, and I sometimes prefer if we could have balloon mounted stent for intracranial stenosis. It's much easier, I think, than, for example, self-expanded stent for intracranial stent.
Okay. Thank you so much.
You're welcome.
Thank you, Dr. Merkur. Thank you very much.
Thank you, Dr. Farah.
Any question from the audience?
No, I think, Dr. Osame, it is a good opportunity if we can, I think, we can design a trial for resistant cranial stenosis in the future.
Yes, of course.
Cooperation of both country or other countries about these cases. If we can,
and if any changes, we can make it and consider it, and then.
Yes. Thank you. Dr. Osame? Dr. Mehpur?
I hear you.
Thank you. Thank you for good presentation.
I think we have some problem in network, but I agree with you, Dr. Faroudi. I think at first we need.
Thank you.
We need a good survey for really we should know about the rate of the intracranial stenosis, especially in our country. As Dr. Osama said, we should certainly determine how much we have it, and then we should have a good clinical trial between different all countries.
Yes. I think very good opportunity and good issue for research. Thank you. Thank you.
Yes, I'm sorry, I lost the connection and returned back. So I think, yes, Dr. Mahdi, we can design some protocol regarding this trial, and we can disseminate it to our board in MENA-SINO and start to have our enrollment for those kind of patients.
Yes.
Okay.
Yes. Dr. Mehpur, as I introduced, is our new president of our Iranian Stroke Organization. It is very active in national stroke movement in our country. With Dr. Zamani, the past president of our country.
It's a pleasure and honor
to appreciate Dr. Mehpur.
And it's our pleasure also to introduce with you, and I hope that we could cooperate each other in the future as much as possible.
Thank you.
Thank you so much.
Thank you.
Thank you for joining us. Thank you.
Thank you. I think Dr. Sharifpur don't join the meeting. I think in the future, I think we can join with Dr. Sharifpur for other colleagues.
Okay.
Thank you. Dr. Osami, other issue?
Yes.
Do you have other issue for discussing?
I think with this we finished today the webinar, and I think if there is no question from the audience, so we can conclude the session.
Okay. Thank you. Thank you.
Thank you, Dr. Mahdi. Thank you, Dr. Masoud. Thank you.
Thank you, Dr. Osama. Thank you.
Thank you. Have a nice day. Bye-bye.
Thank you. Have a good time. Bye.